Okay, so we're going to talk a little bit about hypertension and hyperlipidemia. So it's sort of the big two, if you will, in cardiovascular disease, because it's something we see all the time. Hypertension, probably one of our top 5 diagnoses that we see in the office. And it's sort of a no-brainer that we know controlling blood pressure reduces stroke, reduces heart disease, and reduces kidney disease. So again, that's impelling reasons why we want to try and get these people under control. It also is a huge amount of visits per year, and up to a third of our patients don't even know they have high blood pressure. So if you look at that, about 30% are unaware, so that means 70% are aware. About less than a third or 2/3 of those people are actually under treatment, and only about a third of them are actually at the goal at less than 140/90. So sometimes this is a useful thing for ambulatory blood pressure monitoring, especially if you have that patient that comes in that has the white coat hypertension. Doc, I only have blood pressure when I'm in your office. I always joke, I only have blood pressure elevated when I'm in the dentist's office, and I hear the drill. But those patients aren't at no risk, and so ambulatory blood pressure monitoring may be useful. And you get a number of readings. You don't want to just rely on your clinic readings before you make that diagnosis. You want a number of them so that these patients really, truly do have high blood pressure. The Preventative Service Task Force says screen for those over 18. It's an A recommendation. It's actually really easy, right? Take a blood pressure. How do you screen? It's probably the easiest recommendation we get to follow. What we're looking at is trying to avoid our target end organ, heart, brain, kidney, and then we'll throw in peripheral vascular disease. And we always look for those, if you will, causes of blood pressure elevation. So things like sleep apnea, renal vascular disease, coarctation, some of your aldosterone syndromes that we'll talk in endocrine, and some of the things like pheochromocytomas, thyroid disease that everybody looks but doesn't account for most of this because most of this is essential hypertension. But it's nice not to miss things like a coarc. It just makes for a bad day. Some of the routine laboratory testing, again, some controversy as to whether you want to do a baseline, things like EKG. A lot of that is without symptoms. There are a fair amount of false positives, and so you have to sort of weigh whether or not you want to do a baseline EKG as something to do in the office. Again, it may or may not be covered. Things like urines, depending on whether they're diabetic, may also want to do urinary albumin excretion. Lifestyle modification. One of the things that you have to realize, every single blood pressure trial is predicated on the assumption that they're already doing this, lifestyle modification, that they're trying to follow a better diet, that they're looking at reduction in sodium, that they're doing physical activity, that they're doing moderate alcohol consumption. And look at what moderate is: no more than 2 drinks for men, 1 drink for women. And that's define a drink. 12-ounce beer, not a 40-ounce malt liquor. That's the equivalent of 6-pack. 5 ounces of wine or 1.5 80 proof. So you look at that, and there's a number of studies that say people that drink more beer than 12 ounces, they can raise their blood pressure anywhere from 2 to 7 millimeters of mercury in the systolic. And that just by stopping alcohol, you can drop the blood pressure. So some of the preventative service, again, looks at healthy diet recommendations. It's a grade C, and I know Skeet talked about C recommendations, to look at counseling our patients for dietary and exercise. It's just a good idea, but again, the evidence is neither for nor against. It's sort of weak. In those that are obese and who have cardiovascular risk factors, however, it becomes a grade B recommendation that you should offer a dietary advice and intensive counseling, possibly referring them for behavioral counseling to try and get them to initiate a healthier heart diet and or exercise. Okay, Al's a 56-year-old, convinced by his wife to see a doctor. Nobody ever hears that, right? Why is your wife making you come in? After several years, persistent blood pressure 170/90, 2 packs a day for 38 years, no chest pain, shortness of breath, or headache. What's his blood pressure goal? 90 over 50, right? Yeah, 140 over 90. So if you look at the old recommendations and the new recommendations, what was referred to as JNC8, which was an interesting study in the politics of medicine and the National Heart, Lung, and Blood Institute guidelines, they were commissioned to come out with JNC8, and then the National Heart, Blood said, we're not going to do that anymore. You're on your own. So this was the majority opinion of the people that were on that panel, not without controversy. And so they look at recommendations, but what they focused on was a much narrower set of clinical questions. And they looked at, if I initiate blood pressure treatment, does it improve outcomes, specifically cardiovascular outcomes? And does, again, with that, if I do pharmacologic treatment, does it improve? And are there harms or benefits in specific classes? It decided to not be the all and end all for all of hypertension like JNC7 tried. And it was based on basically a lot of good clinical trials, not all trials, but really randomized clinical trials. So the recommendations which were made were in the general population greater than 60, our target systolic blood pressure should be less than 150. In that patient who was less than 60, our target blood pressure, again, the diastolic should be less than 90, and you're actually going to look at the third recommendation, which puts it in, and our systolic should be 140. Isn't that nice? So we have two targets: over 60, 150 over 90; under 60, 140 over 90. None of this 135 over 85, 130 over 80, 120 over 70. It's two recommendations. Because the patients with chronic kidney disease, our blood pressure goal is 140 over 90. For our patient with diabetes, our blood pressure goal is 140 over 90. And so again, there was a little bit of controversy here about dropping that 130 over 80, but it wasn't supported in the randomized clinical trials. So they went back to the 140 over 90. And then the next couple of recommendations talk about what specific medications we might want to use. In the population, including diabetics, but non-black, the initial treatment should be one of the four categories: thiazide diuretic, calcium channel blocker, ACE or ARB. Interestingly, what's not there? Beta blockers. Completely taken away. And again, they looked at when all comers and all the studies are compared, the cardiovascular and cerebrovascular and kidney outcomes for any one of those classes were essentially identical. So that's why I said any one of those four groups of drugs could be used. The thiazide and the ACEs, if you have also a history of heart failure, were probably more useful. And they didn't recommend beta or blockers or alpha blockers as first line. And most of these patients are going to be on more than one blood pressure medicine. So it makes sense that if you start with the first line agent and you've gone to the appropriate dose and they're still not controlled, you would add a second first line agent. So if they started with hydrochlorothiazide and you maxed it to 25 or 50, wherever you want to go, and they're not better, you might consider adding an ACE, not necessarily a beta blocker. And again, in African Americans, including those that were diabetic, their blood pressure, they said, start with thiazide or calcium channel blocker. They're less responsive to your ACEs. And again, that comes back from the ALLHAT study that said there was a definite improvement in when using calcium channel blocker compared to the ACE ones. In patients that have chronic kidney disease and hypertension, either your initial drug or your second drug should probably be an ACE. And if they don't tolerate, then an ARB. Interestingly, no recommendation they have to get above 75, especially on that one. And then finally, we're trying to obtain and maintain that goal. So where do we see these patients? If they're not better in a month, we would add a second drug. Or if they're, and again, you would do that from the same class. If they've not gone with two drugs, you can add a third drug and titrate. And again, the combinations, ACEs and ARBs, make no sense. They don't increase the benefit, but they increase the side effects and the expense. If they're really not a goal and they're taking it, they're measuring it, they're adherent, and they're still hypertensive, this is where you might employ some of your hypertensive experts. Because at this point, they would say they met the definition of hypertension resistance. This just again shows you that guideline, which is included in there. Follow-up monitoring, you want to have them back probably at monthly intervals till their blood pressure is controlled. Once they're stable, the sort of consensus recommendation is every 3 to 6 months. The British and some of their NICE literature says every 6 months. And you probably want to look at potassium and creatinine at least once a year, especially if you started with your diuretic. There are lots of controversies, and again, you'll see that in the literature. There was some initial data out of the SPRINT trial that said maybe we should be less than 140/90, especially to lower cardiovascular events. Still debated, depending on, because that was one study. Some of the other studies later on said, well, maybe not so fast. And it is interesting because even on those studies where they tried to get lower, their average blood pressure was about 132 to 134/90. So it said, okay, let's just stay with 140/90 and 150/90. Because when you start to push this lower, you have the number needed to treat, again, over the trial was 3.25 years. The cardiovascular risk was decreased either by 61, 90, or 172. At the same time, the number needed to harm was 46. So again, 1 in every 46 patients had some adverse effect. So that's why I said there's a lot of controversies on the JNC. I'll put it another way. If you take 1,000 patients and you treat them, 16 benefit, 22 seriously harmed, 962 patients derive no benefit. And which one of those is your patient, right? So that's what the country. There are some special situations in hypertension. Those, again, we look at older individuals, patients that have increased risk for volume depletion, Parkinson's, diabetes. You want to avoid a lot of volume depletion. That's where you might start with something other than the diuretic if they're at risk. And then children, our definition of blood pressure is, again, greater than the 95th percentile, and you have to adjust for age, height, and gender. And a lot of these often require some additional assistance with our pediatric hypertension specialist, but don't miss the coarc as the cause of the high blood pressure or an undiagnosed kidney disease, because again, that may be amenable to treatment. There are urgencies and emergencies, and there's resistance we talked about. The blood pressure here, if it's elevated, the question that you have to ask is, do they or do they not exhibit end organ damage? Are they confused? Are they disoriented? Are they having chest pain? Do they show signs and symptoms of congestive heart failure? If they're hypertensive and they have that, that's an emergency. Those patients probably need to be admitted and their blood pressure controlled as well as treating some of the underlying condition. If they have none of that, they need to be treated, but they don't need to be necessarily admitted. And nor do you have to initiate treatment like right there. Again, I work urgent care. I have people come in, blood pressure 210/140, no symptoms, no blood pressure medicines. I don't need to admit them, but I do need to get them on something, and they need to see their primary care physician, right? When you look at the resistant hypertension and they're on 3 drugs, just make sure they're not overloaded in volume, they're not taking their medicine like they should, you know. So you ask the patient, how do you take it? I don't know, I walk past the TV and I take a scoop and off I go. True story, which is why she had her CVA. She wasn't taking her blood pressure. Non-steroidals, again, go back to that. Again, they may be not telling you about it, so ask about it. And some of the inappropriate combinations, ACE, beta blocker, ACE, that sort of thing. So they may be what causes resistance. So enough on blood pressure, we beat that to death. Let's talk about hyperlipidemia. Again, some differences in who you look at and who you do the recommendations for screening. For the U.S. Preventive Service Task Force recommendations actually came out in November of last year. And they say for primary prevention of cardiovascular disease in your adult between 40 and 75, you want to calculate that 10-year risk. If it's high, then that's your universal screening. The direct evidence for benefit, harm for younger individuals is yet unavailable. So they made no comment. That's an I recommendation. The ACP says we should screen people starting at, men 35, women at 45, younger if there's risk factors. That's a good family history. So here's 51-year-old considered for pharmacologic treatment for his hyperlipidemia because his LDL was 180. Before medication, he should be screened for hyperthyroidism, hypothyroidism, Addison's disease, or Cushing's disease. Any of you had hypothyroid patients with elevated cholesterol? Yeah, hypothyroidism. So, whoops, pushed the wrong button. Sorry. All right, so the guidelines here, they do differ, and again, depending on if you're doing that, they're limited in their scope. That, if you will, it was the old ATP3. These are the new guidelines that came out of American College of Cardiology. They, again, tried to focus narrowly and looked at only good quality randomized clinical trials. And you're going to see that that's in parentheses, it means statins. That's it. If there were no good recommendations, they made no recommendation. If there was they didn't try to be the replacement for our clinical judgment. I always like when we get told that we can actually think. It's a good thing. And so you may have a patient that you may depart from the guideline after a good discussion, and that's okay. So these were designed for patients over 21, and they were both used for both primary and secondary. And so they identified 4 risk groups, 4 statin groups. And when they're talking statin, that's because that's where all the clinical research is. They looked at high intensity or moderate intensity statin. So gone are the low dose, 10 milligram, medicines, and the high dose. And basically that really tells you there's 2, atorvastatin 80 or rosuvastatin 40. And then if you're going to do the higher doses, you have to look at some of the side effects. They looked at, the one comment was, all the randomized controlled trials did not support LDL and HDL goals. So they didn't really help us in terms of reducing risk for cardiovascular disease. So they created a new calculator, not without its own controversy. It's not the Framingham calculator. It's a new calculator. You can actually pull it off the App Store and put it on your phone, and it'll do the risk calculations for you. And so a lot of this is we need more studies. So the thing here that we'll look at is that they didn't say there was any reduction whether you have heart failure or hemodialysis. So they took that sort of out of the equation. And so all of that, again, is predicated on lifestyle modification. Same thing for blood pressure problem. All of the randomized trials for all your cholesterol agents is assuming that they're on this. So that was sort of your background. And they said, here are the 4 groups. Patients that have known coronary artery disease, atherosclerotic disease, or its equivalent. So they had a carotid endarterectomy. They should be on a statin. They're at risk. That's group 1. Group 2 is patients who are clearly at risk whose LDLs are greater than 190. Nobody's going to argue with that one. Diabetics from 40 to 75 with LDL-Cs somewhere between 70 and 189. So they're not meeting the 190 criteria, and that's with or without atherosclerotic heart disease. So again, why? Because diabetics are a coronary artery risk equivalent. So as you could say, but they're the same as your group 1. And then patients who don't have atherosclerotic heart disease or diabetes, whose LDLs were, again, that range 70 to 189, who have an estimated 10-year atherosclerotic risk using the new calculator of greater than 7.5, they should probably be offered statin therapy. In our operational definitions, they talk about primary and secondary. Again, just trying to make sure we all are on the same page. The argument here was if you have a diabetic who's got an LDL of greater than 190, you don't need to use the calculator because they're diabetics. In fact, you don't need to. That's that special category, the diabetics. This again shows you this right out of the article, the 4 groups that need to be treated. And as I said, the statin guidelines got changed in November. So they say low to moderate in patients that have no history of cardiovascular disease, but who have at least 1 or more cardiovascular risk factor and or a calculated 10-year risk event of greater than 10%. And the cardiovascular risk factors are dyslipidemia. And Bob and I were arguing this back and forth. That's an LDL greater than 130, diabetic, hypertensive, or they're a smoker. So that's that new recommendation. You should do low to moderate in those patients who don't have the cardiovascular history, but who have a risk that's between 7.5 and 10. If you look, that's a C recommendation. So, and then insufficient if to look at screening anybody over 76. Now, I do a lot of hospitals and I do a lot of geriatrics, and it never ceases to amaze me that the 95-year-old wants their cholesterol screened. Why? There's no we don't see any benefit, we don't see any advantage, and so the recommendation is don't do it. Again, isn't that nice? They say there's some imprecision in older adults. They might need that risk in the absence of cardiovascular disease, and so you have to use your clinical judgment, especially in that 65 to 70-year-old. And they don't recommend screening people under age 40, if you will, unless there's a real good, compelling indication. So like every male in their family's had an MI by 40 or 30, maybe, but there's lack of evidence and lack of trial. So that's right out of the November guidelines. And as I said, the perspectives here, there's a lot of debate about giving up goals, but there's really no good literature that says goal-directed therapy was of any benefit decreasing atherosclerotic cardiovascular risk. So the other thing is that as of now, and that might change, there's no data that's showing adding non-statin therapy to a high statin regimen decreases any cardiovascular risk. So it sounds like, gee, was this industry sponsored? Probably. There's the two big studies, AIM High and Accord, showed that if you added femfibrate or niacin, it didn't decrease your cardiovascular risk. And most of these patients, especially those that are greater than an LDL of 190, you're not going to get to that goal of under 100. You may get them to 120. You decrease their cardiovascular risk regardless. Again, even if you could reduce it by 50%, there's risk reduction. So that's why I said there's not directed toward goal. And the goal directed here in the diabetics is, again, get as low as you can. Now, there's some people that argue about what are some of the biomarkers, calcium artery scores, highly selective C-reactive protein. Do they have any benefit? And there's, that may be where you use some clinical judgment because they don't fall into any of one of the categories. So they score and their risk is 7%, but they've got, significant other issues, ABI is less than 0.9. You may put them on therapy as well. And as I said, here's the differences between high, moderate, and low intensity. Pretty much the low intensity is really based on the U.S. Preventive Service Task Force. But if you're doing treatment of one of those four groups from the recommendations, it's the high dose. If they can't tolerate high dose, then it's the moderate dose. And this, again, just shows you how you can work through that, the different dosage. Lots of arguments about safety of statin. And you've all had patients come in, you put them on it, they complain of muscle aches, okay? And most of the time, they have to, have been on that for a while, and look at something that can comment at other drugs that can interact. The patient that has increased risk for side effects are usually the older individuals. Interestingly, we have to be careful with the higher dose intensity statin in a couple groups. Prior hemorrhagic stroke and Asian ancestry may have more problems with side effects. The recommendation is not routinely monitoring CKs unless they start having major symptoms. The argument about liver enzymes also is somewhat debatable, probably at initiation, and then maybe one other time unless they develop signs or symptoms of hepatotoxicity, because in the first 12 weeks of initiation of therapy, a lot of your transaminases are going to transiently elevate. So you don't want to catch that blip. They do recommend if the patient is on statin and is not diabetic, you might at least screen for that. There is a couple studies that suggest there's an association with statin use and an increased risk for type 2 diabetes. And it shouldn't be used in women that are wanting to bear children because it's a category X. The myalgias are usually benign. It's often switching or changing out the dose. Occasionally, some people add coenzyme Q10. Most of the time, this goes away and resolves if you discontinue the drug. Myositis is a definition of greater than the CPK of 10 times more upper limits of normal. the recommendation is either reduce the dose, switch the statin. So sometimes the things like pravastatin or fluvastatin may be more tolerated than atorvastatin. And then the rarest of all is rhabdomyolysis. It's 4 in 100,000. If you have a patient that has rhabdomyolysis, usually concomitant with nitrates and fibric acids, these patients should never be rechallenged with statin unless you want to have what we used to call 1-800-CALL-LEE-FREE, right? That's one of the layers. The calculators are there. That's one of the online. The last time I looked, it still worked. Again, there's an app on the phone to pull down the calculator. There's, again, controversy because you look at, and it says, boy, only just put it in the water. All right, Skeet.